Hi, I'm Kimberly Odell, and I'm a third-year cardiology fellow. Today I'm going to talk to you about recognition and management of acute coronary syndrome after surgery in the PACU. So PACU complications in cardiac patients. Cardiac patients are at risk of having complications with non-cardiac surgery, and the data shows that up to 17% of patients undergoing non-cardiac surgeries do in fact have myocardial ischemia or infarctions in the postoperative period. There are unique challenges to diagnosing acute coronary syndrome in the PACU, most often because patients are still anesthetized or they're getting pain medications and they may or may not have symptoms. And because of this, there is significantly increased morbidity and mortality in these scenarios. So acute coronary syndrome is defined by a reduction in coronary perfusion that impairs cardiac function. And acute coronary syndrome includes unstable angina, non-STEMI, and of course STEMI. So the pathophysiology of perioperative MI. So surgery is a controlled trauma to the body, and it induces an inflammatory cascade and a stress response. The inflammatory cascade allows immune factors, factors for healing, and coagulation factors to perfuse through the body. It leads to vasodilation, and that can lead to hypotension and intravascular hypovolemia, as well as thrombosis. The stress response is a neuroendocrine process and leads to a catecholamine surge, and it allows for electrolyte retention, volume retention to kind of counterbalance the other effects. And the hypertension and tachycardia that results from the catecholamine surge can lead to cardiac complications and increased cardiac demand. It can also lead to increased shear stress within the vasculature, especially in patients with underlying coronary artery disease. And these inflammatory and stress responses can result in labile hemodynamics, hypercoagulable states, and can induce plaque rupture from the catecholamine surge, which can precipitate myocardial injury, ischemia, or infarct, particularly in patients with underlying cardiac disease. There's also supply-demand mismatch, particularly in patients with coronary artery disease. And in these patients, their coronaries are at baseline narrowed. And so when you're under the stress of surgery or anesthesia, you require more blood flow to the heart. And the heart is just demanding more blood. And these vessels are already diseased and narrowed, and they're unable to augment that blood flow in the way that it should be able to in a patient without underlying coronary disease. And this can lead to ischemia. And other causes of supply-demand mismatch include fever, hyperthermia, hypothermia, tachycardia, hypertension, anemia, hypovolemia, hypoxia. All of those can happen after surgery or while under anesthesia. Signs and symptoms of acute coronary syndrome classically include substernal chest pain, tightness, pressure, heaviness sensation. Patients often report a radiation of that pain to the jaw or to the arm or shoulder area. They may report epigastric discomfort, may have nausea, vomiting, may have sweating, pallor. In the PACU, patients are often under the effect of the anesthetics or under the effect of pain medication, so that may mask any symptoms that they would otherwise have. And therefore, you must rely on clinical signs and objective data for diagnosis of acute coronary syndrome. And so that includes hypotension that is persistent despite volume resuscitation or blood resuscitation in the setting of anemia, EKG changes that occur on the telemetry monitor or on 12-lead EKG, arrhythmias that are new onset or worsening in frequency, such as more frequent PVCs or VT, even VF in extreme cases. You can have decreased oxygen saturation, crackles on exam, respiratory failure, diaphoresis, pallor, and increased cardiac biomarkers, which typically consist of troponin here. EKG changes that you should be able to pick up on include T-wave inversions. In this EKG, I've placed blue arrows to point out T-wave inversions, and these would be new changes. So if you have a baseline EKG to compare the new EKG to, that is always helpful. New T-wave inversions can signify ischemia in a certain area of the heart. And the other would be ST depressions. ST depressions typically are 1 millimeter or more in depth, and they must be in 2 or more contiguous leads. Unstable angina may be difficult to diagnose in the PACU because really for the diagnosis, the patient must be able to report symptoms of increased or worsened severity of pain or the frequency of pain if they have underlying stable angina. EKG changes may or may not happen in patients with unstable angina, and then troponin may or may not change as well. So you really have to use clinical judgment for these patients. And management would be to go ahead and give aspirin 325 milligrams or 600 milligrams PR if the patient's unable to take oral medications. And then you want to target causes of increased oxygen demand, such as fever, hypothermia, etc. And then consult cardiology for further recommendations. Non-STEMI would be probably the most common issue that comes up in these patients in the PACU. And these patients, again, may or may not report symptoms. So they may be under the effects of anesthesia. They may have pain medicines, which would mask any pain that they may or may not have. So you have to watch for the clinical signs that we discussed: hypotension, tachycardia, EKG changes, sweating, vomiting, those types of things. The EKG changes will include the T-wave inversions and ST depressions. It can also include new Q waves, which we'll show on a EKG a few slides down. And then elevated troponin. So if you have a baseline troponin to compare this to, it is often helpful because a lot of these patients will have elevated troponin at baseline, and you want to see that it's elevated above that, or that there is a rise or a upward trend in the troponin level over time. And management also includes giving aspirin 325 or 600 PR, and you want to aggressively treat the causes of increased oxygen demand. So again, the fever, hypothermia, hypotension, hypertension, those things. And then consult cardiology for further recommendations. Pathophysiology of STEMI is different compared to unstable angina or non-STEMI in that it is a sudden, complete occlusion of a coronary artery. So in non-STEMI or even unstable angina, you may have narrowing or stenosis of the coronaries, but STEMI, you're having a total occlusion. And most commonly, this is due to an atherosclerotic plaque rupture and subsequent platelet aggregation and thrombosis, which leads to that total occlusion. Other causes may include, from a hypercoagulable state, you may have emboli to the coronaries. You may have a spontaneous coronary artery dissection related to a catecholamine surge, most often occurring in middle-aged women. And you could have a severe vasospasm, or in patients who had recent PCI to the coronaries, they may have a stent thrombosis. For STEMI, it's important to elicit any symptoms that the patient may have if you're able to communicate with them. Severe, unrelenting chest discomfort. They may have anxiety or that feeling of impending doom. They may become diaphoretic or have pallor, nausea, vomiting. Signs would be hypotension. It can also manifest in overt shock. They may have non-sustained VT or sustained VT, ultimately VF, and cardiac arrest. They may start to have shortness of breath and pulmonary crackles, respiratory failure. They may have vomiting, diaphoresis, and they may have altered mental status. EKG changes we'll touch on the next slide. And it's important to note that when you check a troponin in a patient with a STEMI, the initial troponin may be negative or normal. And that's because troponin does not rise in the bloodstream until about 2 hours after the initial insult. And with STEMI, it's an acute total occlusion, so it's going to take time for the troponin to be elevated. So don't rule out a STEMI based on an initial normal troponin. Management includes a stat cardiology consult, so you can do that by looking on Amion and calling the on-call provider, or you can send a message through Epic Chat to BEH Cardiology Consults and put in the chat that it is a stat consult for a STEMI. And you also have to fire the STEMI pagers. So to do that, you call EROC or bed desk at extension 1111, and they will contact the appropriate parties, including the interventional cardiologist and the cath lab staff. And you also want to give aspirin 325 PO or 600 milligrams PR immediately. EKGs for STEMI can be subtle or they can be fairly obvious. The first EKG here shows ST elevations in the inferior leads, so leads 2, 3, and AVF, and those are marked with the large downward pointing blue arrows. This also shows some developing Q waves with the upward pointing blue arrows. And this patient also has some posterior extension of the STEMI, which is denoted by these blue stars in leads V1, V2, V3. The EKG on the bottom there shows a posterior MI, which is very difficult to recognize at times because it is a STEMI, but it does not present initially with ST elevations. So you would have ST depressions in V1, V2, and V3, and then giving the other clinical signs or any symptoms that the patient's having, that would prompt you to get a posterior EKG. And so the EKG tech would put leads on the back of the patient, and then that would give you a V6, 7, or 7, 8, 9, and that would show the ST elevations. The other EKG there is a much more subtle presentation of a STEMI. So you have some very slight ST elevations in V3 or lead 3 and AVF, and then you have some reciprocal changes in the lateral leads. So I hope this presentation was helpful and will help you pick up on any cardiac complications in the PACU for the post anesthesia post-op patients.